Hi, I'm Matthew Weinstock, Senior Editor for Hospitals and Health Networks. Thanks for tuning into our Executive Insight series. Hospital leaders are eagerly awaiting the final Stage 2 meaningful use rules to come out of the Office of Management and Budget. But even as those regulations get one final review, CIOs are pushing their hospitals along towards IT adoption. I'm joined today by Pam McNutt, CIO of Methodist Health System in Dallas, Texas, to talk about where her institution is on its IT deployment and where she sees the field moving. Pam, thanks for joining me today. So let's talk a little bit about where Methodist is in its IT journey and where you are in getting ready for meaningful use.
Well, Methodist has met meaningful use stage 1 at 3 of its 4 fully owned facilities. And we are testing right now on the 4th one. So that feels really good, and that took a lot of hard work to get there. So we're not just taking this opportunity between now and meaningful use stage 2 just to cruise. We are going, full speed ahead with requirements that we think will be in stage 2 and that we also need for some of our ACO, Medicare shared saving program activities.
What have been the biggest challenges for you in getting ready for not just meaningful use, but really bringing your system up to an IT level where you're comfortable with it?
Clearly the biggest challenge is the clinical integration prospect of really trying to get the physicians using evidence-based tool sets and getting those tool sets built, the sheer manpower it takes to bring about that collaboration with your physicians, your nurses, your pharmacy systems. That's clearly been our biggest challenge.
So we're waiting for the Office of Management and Budget to approve Stage 2 meaningful use final regulations. Not knowing yet what exactly is going to be in there, what can the field be doing now to prepare for Stage 2?
Well, clearly there's a lot of overlap in Stage 2 and the kind of activities that organizations need to be doing to prepare for ACOs and the shared savings program. And Methodist recently did receive the nod to be in the Medicare shared savings program. And so a few things that we're immediately engaging in is connecting up to an HIE, having that inner connectivity and exchange between your providers, including your post-acute providers in the long run, is going to be critical as we move this out. Now, in this early stage of the shared savings program, really it's all about data analytics. But even to do the data analytics, to figure out which patients you need to go do care management on, you need to have some normalization of data, which brings me to one of the really big and hard tasks in meaningful use stage 2. It's even been a challenge in meaningful use stage 1, trying to do the quality metrics, is mapping and normalizing your data to all these standards. But that's really the only way that you're going to be able to exchange data in a meaningful fashion.
Right, and you referenced the Medicare ACO program. Talk to me a little bit about the connection then between IT and moving to that ACO value-based model. How do those work together?
Well, it's been said by others that some of the failures of some of the other models in the past have been that we did not effectively use data to, one, predict what kind of care patients are going to need and also to manage the care. And so clearly there's a heavy IT component. The thing right now, though, is it's very confusing to figure out which of these various components you should put in place first, because there are many vendors out there that are knocking on your doors once you get the nod for this program, wanting to sell you all kinds of data analytic tools, care management tools. There's just hundreds of vendors and solutions out there. And so as I talk to my colleagues, we're all sorting through all this, trying to figure out what's the biggest bang for our buck right now. If we could only buy two pieces of IT technology, what is it that you really need to go out there and have day one? And clearly, I think it's being able to identify the risks in your population. You can have a lot of fancy tools to notify people of this or that, but it's really the basics, figuring out what you really have and what patients are at risk. That's the foundation.
All right. Well, Pam, I appreciate you taking some time today.
Thank you.
I'm Matthew Weinstock, reporting for HNHN Daily. Thanks.